This episode is brought to you by the Fempower Health Chronic Pelvic Pain channel. And if you're not subscribed and want to learn more about chronic pelvic pain, make sure to subscribe where you listen to podcasts. You can search for Fempower Health Chronic Pelvic Pain channel or click the link in the show notes. And if you're interested in perimenopause and menopause, we also have a dedicated channel for that. Search for Fempower Health Perimenopause Menopause channel to explore more.
Endometriosis, if you go to PubMed and you put in endometriosis, you'll probably come up with 50,000 articles. If you put in adenomyosis as a search term in PubMed, which is what we use for doing our medical research, it probably comes up with maybe a few thousand.
Welcome to Fempower Health. This is Georgie. I am thrilled to be joined today by Dr. Ken Sinervo, an internationally recognized expert in chronic pelvic pain, including adenomyosis and endometriosis. Today, we're diving specifically into the complexities of adenomyosis, a condition that, while similar to endometriosis, presents unique challenges for diagnosis and treatment. Dr. Sinervo will break down how adenomyosis impacts fertility, why it's often misdiagnosed, and the treatment options available beyond hysterectomy. His years of experience at the Center for Endometriosis Care offer invaluable insights into navigating this condition, and I am excited for all you will learn from him. Dr. Sinervo, thank you so much for joining me on the Fempower Health podcast. As I was saying, I can't believe it's taken me this long to interview you, and I'm just so honored that you are joining me today. I know you are so well respected in your field, and today we're here to talk about adenomyosis because endometriosis is getting so much attention, and I feel like this is a topic that we need to talk about more. And so I really wanted to highlight it, and I know you're the expert to help educate us. So before we dive into this, why don't you tell us about your background and your wonderful center that you run?
I've been in practice for 25 years. I joined the Center for Endometriosis Care in 2000, just after my fellowship. And I did a fellowship in advanced laparoscopic surgery, and I kind of was blessed to fall into this opportunity to treat endometriosis, which at the time was getting very little effective surgical treatment. We were one of the pioneers in, having a multidisciplinary team in laparoscopic excision of endometriosis. So I really found that it was a wonderful niche that was really, serving an underserviced area. Endometriosis affects 10% of women, so it's a huge group of women that were really being neglected and unfortunately getting poor surgeries that were ineffective by the majority of gynecologists out there. And when we had been using other specialists for many, many years, but it wasn't the standard of care to have a multidisciplinary team to treat endometriosis completely. So a general surgeon or colorectal surgeon, a thoracic surgeon, and a urologist that we work with surgically so that we can address all the different aspects of endometriosis. And really was something that we were doing, over 25 years ago. And it really only kind of caught on maybe, 8 or 10 years ago in other centers. So we really had a leg up, and I've been the medical director for probably 20 years now. And so I've been really blessed to be able to have treated, over 10,000 women over those 25 years. And we have, I think, a very successful practice that, cares about patients and spends the time with them and follows up with them appropriately and offers them really, some of the best surgery of anywhere in the world.
Wow. Yes, no, it is very true that the multidisciplinary team is so critical. And I'm seeing that concept catch on in so many other areas of women's health. It's so critical. I mean, our healthcare system is incredibly siloed. And for something like endo, where the diagnosis, really the standard of care right now is surgery, and then the treatments, some of the ones that are available aren't so wonderful from a medication perspective, but then surgery has to be done right when it's time for the surgery. And this is why so many people are coming to you, and I bet you have a wait list.
Yeah, I operate probably more than anyone else in the country. I do about 350 to 400 cases a year. And, I think the average busy endometriosis specialist maybe does, 200 to 250.
Right.
So we try to be able to keep the wait list down so that patients aren't waiting too long. They get frustrated if they have to wait longer than the 10 years they've already been waiting.
That's right.
You even just get diagnosed, and many of them have had multiple surgeries already, which has even been more frustrating because each surgery they're hoping that that's going to be the last one.
Yeah.
And
No, absolutely.
unfortunately, a lot of the time I'm kind of their last hope because they've
Yeah.
had so many failed surgeries. So.
Yeah, I know it's and as I mentioned, I like to interview the experts who, fortunately or unfortunately, you're the last line of hope for women, and I want people to hear from the last line of hope now. So you're the first line of hope, and not that 10-year journey. So I'd
Exactly.
love to talk to you because I know you deal so much with different chronic pelvic pain issues, and adenomyosis is one of them. And I feel like it's just not talked about enough. Either it's not in my inner circle, but I feel like the noise, so to speak, is so much around endometriosis, including some recent wins around funding for research. So let's help us understand, what is this difference between endometriosis and adenomyosis? And I'm assuming you're seeing a lot of it in your practice as well.
Yeah, absolutely. They kind of go hand in hand a lot of the time. By definition, endometriosis is endometrial-like tissue that is growing outside of the uterus. Okay, so it typically involves other structures like the ovaries, fallopian tubes, bowel, bladder, pelvic sidewalls where the ureters lie, even the diaphragm and the lung, and very rarely other areas as well. Adenomyosis, the simplest way to think about it is kind of like endometriosis within the muscle wall of the uterus.
Okay.
So the tissue that makes up the lining of the uterus or something similar to it is growing in the muscle layer of the uterus. And so what happens is the uterus almost acts like a big bruised muscle. So every time that you menstruate, those little pockets of endometrium within the muscle, they respond hormonally as well. And just like you would have with a period, those are kind of almost bleeding internally within the muscle, causing inflammation within the muscle. And a lot of the symptoms emanate from that. So if you have a painful uterus, unfortunately, the uterus doesn't contract as well because the muscle fibers don't line up like they normally should. And patients have heavier, clottier bleeding. There's nerves that come off the back of the uterus. So the patients often have a lot of back pain. They may have a lot of pain with intercourse, which can also be seen with endometriosis. Sometimes if you have a painful uterus sitting over top of the bowel, patients will have bowel symptoms associated with it because the uterus sits behind the bladder. You have the bladder that fills up on it and may have irritated bladder symptoms as well. And so there is a lot of overlap between endometriosis and adenomyosis, but you really have to try to differentiate the two, sometimes based on having treated their endometriosis and they're still having pain, which often will suggest that the uterus is part of the component. But also when we look to patients who have adenomyosis, they may have kind of cramping all the time, which is kind of a pathognomonic sign that they have it because of the uterine irritability. And then the patients may also have, problems with fertility as well, just like endometriosis can cause problems with fertility, because it probably affects implantation much the same way that endometriosis can affect implantation because of the inflammation that is produced from the uterus. And we don't know the exact mechanism by which adenomyosis occurs, whether it's something that's genetically predetermined or whether it's problems with the disruption of the membrane between the endometrium and the myometrium, which is the muscle part, the endometrium being the inner lining that a woman sloughs every month, whether there's a problem with that basement membrane there, and that allows little pockets of endometrium to become invaginated into the muscle layer and work their way deeper into the tissues, causing more and more symptoms. So we probably see it, the studies suggest that it can probably happen, 20, 30% of the time. But even some studies which looked at ultrasound criteria for adenomyosis found as many as 30% of asymptomatic women may have adenomyosis as well. So it doesn't necessarily mean that you have to be symptomatic, much like yourself, who didn't have a lot of symptoms with their endometriosis. At least they didn't pick up on those symptoms because you found out that you had endometriosis as a cause of your infertility. And,
Right.
With infertility, it may account for 25 to 50%. Endometriosis may account for 25 to 50% of cases of infertility. And 10 or 15% of patients with endometriosis have no symptoms either. So, that's why I think a lot of the patients with infertility sometimes get missed, because they may not have a lot of symptoms, but it's there and it's still causing a lot of inflammation for the pelvis and interference between the egg and the sperm.
Okay. So do a lot of women have both adenomyosis and endometriosis? Is there data around the commonality of having both?
Yeah, I think probably around, 20% of endo patients probably have adenomyosis, maybe more. Um, and, that's probably the main reason I do hysterectomies, not because of the severity of the disease. We're able to remove the endometriosis in probably 80% of the patients, even with stage 4 disease, with no recurrence of their pain.
Right.
So, or minimal recurrence that doesn't require reoperation. So that tells us that a lot of the time, the uterus is probably the main reason why they continue to have pain. So, and that's probably the main reason I reoperate in general, not because of recurrences of endo, but because of adenomyosis there. And maybe 5% of the hysterectomies, or 5% of all our endo patients need a hysterectomy because of the severity of their endometriosis per se. But
Got it.
most of it's because of adenomyosis.
Got it. Now, if you have adenomyosis, do you have to get a hysterectomy?
No, there are some other medical and surgical options that may be helpful in alleviating symptoms. Okay. So hormonal suppression may be helpful in, improving some of the symptoms associated with adenomyosis. It's not there. We don't have anything that's going to get rid of it. Just the same way we don't have anything that's going to get rid of your endo medically. But what we can try to do is we can try to suppress it. Okay. And a lot of hormonal therapies will work reasonably well to do that. Some work better than others. I think probably the one that most experts feel probably has the best chance of improving pain associated with adenomyosis is probably a progesterone-coated IUD like Mirena or Liletta. There are other IUDs out there like Skyla and Kylena, but the hormone levels in them I don't feel are quite as high that are released on a daily level to kind of get the same sort of suppression that we might need with, adenomyosis. So I usually recommend either Mirena or Liletta. And I'd say about 50% of patients may have some improvement in their symptoms with that. But it can take 6 to 12 months for you to start to notice that. So it's not a quick fix. And you kind of have to give it a good chance, assuming that you tolerate the IUD well, which probably most, 90% of women do. Okay. The other medical therapy that might be helpful is danazol, which is it's a testosterone derivative, and they can compound it in such a fashion that you can take it as a suppository. And there are some studies to suggest that can help with rectovaginal deep endometriosis. And it may also have some effect on adenomyosis as well, because they probably work in a similar fashion. Anything that is absorbed either vaginally or intrauterine is probably going to have a greater effect than something that's taken orally. Okay. In
Interesting.
terms of birth control, Some of them may not quite be as effective as maybe something like norethindrone, which is it's a commonly used as a form of birth control at lower doses, like 0.35 milligrams in the birth control pill. But for doses that might be helpful for adenomyosis, you might have to take 2.5 to 5 milligrams of norethindrone daily. A lot of patients will have improvement in their bleeding from that, and that may also help a little bit with uterine pain. Okay. In terms of surgical options, there are radical procedures like adenomyomectomies, where if you have a discrete area that has adenomyosis, and this kind of brings up the idea of different types of adenomyosis. So you can have typical adenomyosis, which we feel is more of a diffuse pattern of disease, where the adenomyosis is kind of usually throughout the entire wall of the uterus, predominantly the posterior wall for some reason. That's probably what we encounter most. There can also be patients who have adenomyomas, which are almost like fibroids, but instead of harboring a benign smooth muscle tumor, they harbor a collection of adenomyosis, and it's a little bit more contained and a little bit more discrete, and it'll appear differently on imaging. And those are kind of the two most common variants of adenomyosis that we see. And, an adenomyoma is probably more amenable than diffuse adenomyosis to treatment surgically, because you can go in and just remove that one pocket of adenomyosis and repair the uterus much like you would if you're removing a fibroid. But with diffuse adenomyosis, it's often involving most of the posterior wall of the uterus, and you'd have to remove a big chunk of the posterior uterine wall and then close it back up in multiple layers. And there are some doctors who do these procedures, but unfortunately, they're not very effective at removing all the disease. You're still probably left with some because of how diffuse the disease is. Mm-hmm. You may debulk or decrease some of the volume of the disease, but then you might be left with a weakened uterus, which may be at greater risk of rupture or other complications if you were to consider conceiving with it. It's not necessarily as safe a procedure as, say, a hysterectomy at alleviating your pain and being more definitive. Right. There is another procedure which may help symptomatically, called a presacral neurectomy, where you involve removing some of the nerves that are coming away from the uterus. And, sometimes that can be done in patients who have severe pain that is referable to the uterus, where their pain is midline, a lot of back pain and or suprapubic pain that, on examination, the patient has a lot of tenderness that refers to the uterus. And that may be helpful in alleviating discomfort 70 to 75% of the time. But unfortunately, it's not a permanent treatment. It seems to wear off over time. So patients, after maybe 6 months, maybe 70% are having some improvement in their pain. But by 5 years, maybe it's only a third of patients. So it becomes less effective. And we don't think that the nerves grow back per se, but we probably don't remove all the nerves associated with the nerves that innervate the uterus. So the ones that are left behind just become more active in talking to the brain and saying that there's still a problem going on.
Okay. Wow. So I have to ask, just because one of the things I've noticed in the women's health world is, for a variety of reasons, what we've been taught, what's been normalized, the complicated healthcare system, how we don't have enough research, the list goes on and on. I do see that women tend to really enter the medical system, so to speak, when they want to get birth control and when they're struggling with infertility. And, I'm hearing these discussions of complications with adenomyosis. We've been using the term hysterectomy quite a bit. And so I want to address this before we continue, for someone who may be anxious and they're like, but I'm trying to have a baby. I'm in that part of my life. How should one understand adenomyosis? And I know that's a grand question and I don't want to lead the witness. So I'll just let you start to answer that, and then I can filter in some questions to help clarify.
Adenomyosis again, is commonly associated with endometriosis. Okay. And it can be another reason for miscarriage. We don't know how great the impact is on from an infertility perspective. And there's probably a lot of women who have been able to conceive with adenomyosis. But unfortunately, endometriosis, if you go to PubMed and you put in endometriosis, you'll probably come up with 50,000 articles. Okay. If you put in adenomyosis as a search term in PubMed, which is what we use for doing our medical research, it probably comes up with maybe a few thousand. So unfortunately, it's one of those things that doesn't get a lot of research from a fertility perspective per se, or even a pain perspective a lot of the time. Even when patients come to me and they're trying to work through their endometriosis journey, a lot of doctors haven't even brought up the possibility of adenomyosis to them. And so it's one of these entities, just much like endometriosis is ignored by healthcare providers. You can imagine something that's getting 1/20th the research, how much undereducation there is regarding adenomyosis as well. And so, if the delay in diagnosis for endo is 10 years, what's the delay in diagnosis for adenomyosis? I don't think that's ever really been looked at. And a lot of providers, gynecologists, aren't as acutely aware of what the signs and symptoms and radiologic findings are regarding adenomyosis, and how to specifically look for them, and what to ask patients specifically to see whether or not they think that they have that. Okay. But it is a very big quagmire, I guess, when it comes to fertility and adenomyosis, because there's not a lot that we can do about it. Okay. It's either you try to get pregnant, and if we can get you pregnant, there's a slightly higher risk of miscarriage with adenomyosis. But again, a lot of those patients will be able to carry to term. Okay. There might be a slightly higher risk of preterm labor, because much of the same reason that they're having miscarriages, they're probably having some uterine irritability that may predispose them to preterm labor as well. Fortunately, the risk of preterm labor is small. It's around 6 or 7% in our country. And, but a 50% of preterm labor, still makes it about a 10% chance of preterm labor. And there may be more bleeding during pregnancy because of problems with the membrane between the endometrium and the myometrium, maybe predisposing them to problems with the attachment or implantation of the embryo into the uterus. So bleeding may be a little bit more common in those pregnancies as well. But a lot of patients will be able to get pregnant. And, when you talk to fertility specialists about adenomyosis, it's one of those things that, they don't have a lot to offer. There are some studies that have suggested that longer term use of Lupron, and there are some studies that have looked at anywhere from 3 months to 6 months to 3 years even of Lupron therapy before, implantation in those patients, to try to get the adenomyosis to kind of shrivel up a little bit so that it's less inflammatory. And so, these are all different studies that have been done. Unfortunately, they may help a little bit, but they're not like, oh, well, if we do this, your chances of, carrying a pregnancy is going to be 100% by any means. So, it's one of those things that, again, is probably less well treated by fertility specialists as well. And, doctors who do both endometriosis and infertility may be more acutely aware of it, but that doesn't necessarily mean that all fertility specialists are, because, again, they're focused on the things that they think they can work around, like endometriosis a lot of the time. Yep. But sometimes their workarounds don't necessarily work either. And so we, patients who will have had either poor responses to IVF stimulation or have miscarried a lot, or end up to found out that they have adenomyosis or endometriosis. And then, they kind of get the diagnosis, but it doesn't necessarily help unless, in some cases they get surgery done to improve the environment within the pelvis by decreasing, getting rid of the endo. That if you have endo, there's a good chance, if you have adenomyosis, there's a good chance you have endo as well. And so, just treating the endometriosis may be beneficial to you by decreasing at least some of the burden of the inflammation that is there. And we know that, if you fail 2 cycles of IVF, and you suspect endometriosis, you're probably better off having a surgery at that point, because more rounds of IVF aren't necessarily going to be as effective, because there's a real fall off in the effectiveness of the IVF if there's still endo around after a couple of cycles. So I think a lot of fertility specialists, if they suspect endometriosis, are kind of suggesting that maybe we should be doing surgery on those patients who might have endometriosis, at least the ones who have an immunologic bend to treating infertility, like Dr. Braverman and a few others.
Wow. I mean, I'm listening to this and I'm just thinking, so if I'm with adenomyosis, what I'm hearing, because it's kind of a different world than endo, because with endo, the conclusion that I've reached after all these interviews and years of knowing the community, just because of my own experience as well, is if you get surgery and you get the right surgeon, you should be in pretty good shape. And I'm not exactly hearing such certainty with adenomyosis. And I certainly don't want to scare anyone. But what I'm hearing is at this point, what we're trying to do is manage pain and optimize fertility. Is this one of those where, and this is where I'm hesitant to say, because I tend to be just like, get down to the nitty gritty here, but I also want women to be like informed. At the end of the day, at some point, are women who have adenomyosis going to need to get a hysterectomy at some point in their life, and just they have to plan for it?
Well, some patients, their pain is manageable. A lot of patients who, aren't necessarily trying to conceive, they'll do the Mirena IUD. It'll be effective enough that their pain is better. And that, again, 50% of patients who use the IUD for adenomyosis have improvement in their pain. Yeah, so it's not like all hope is lost. So a lot of patients will be able to manage, but that leaves you with 50% of patients who may continue to have some, element of pain or heavy bleeding that may need to be addressed with, a hysterectomy somewhere down the road. Again, it's probably the main reason that I do hysterectomies, not because of bad endo, which again makes up about 5% of the endo patients I see, and about maybe a quarter of the hysterectomies I do. Okay, I do about 20% of my surgeries are include hysterectomy. A lot of those are patients, 75% of those hysterectomies are for adenomyosis, because we've already treated their endo and they continue to have pain, or, they've completed childbearing and they're still having pain and they want to just have one more surgery and be done with it. And, and that's why it's very important that if you are doing a hysterectomy for a patient for endometriosis, that you treat the endometriosis well as well, and not just do a hysterectomy and leave all the disease behind. 10 or 15% of the surgeries I do are patients who've already had a hysterectomy and their endometriosis wasn't optimally treated. And so, they're left still in the same position as they were before, but now they've had a hysterectomy and they're still having pain. So again, it's very important. It's important for patients to realize that a hysterectomy, if you have endometriosis, is not a cure for endometriosis. Excision of the endo is, right? So, and you've probably been told that by other experts as well.
So if someone has a hysterectomy, the adenomyosis would be gone. That's the complete way to get it.
That is the treatment for adenomyosis. Adenomyosis is by definition a uterine problem. And,
wow. So something black and white in women's health. Oh my gosh. I can't believe it.
Yeah, not a lot, but
No,
that
I
is
know.
one of those things that is the answer to it. Unfortunately, we see all too many patients who don't have their endo treated at the time of a hysterectomy.
Okay, that's unfortunate. So I have to ask you, just because I hear so many stories of even this happening, is fibroids. Now, fibroids can also, even though they're fairly straightforward to see, um, people still get delayed diagnosis on that. So, because of where fibroids are, and I'm thinking of adenomyosis, do you ever see like just I guess tell me what you see if there's any relation in things women should be aware when they're having this uterine pain, painful periods, etc. Have you ever seen this like holy cow, how did this not get caught? Is there any relation here that we should think about or be aware of?
Well, patients who have fibroids may not necessarily have as much pain associated with their cycles unless they're having heavy
Okay,
periods. Okay. So
got it.
fibroids are benign smooth muscle tumors that grow usually within the muscle wall of the uterus, maybe under the lining or kind of on the outer surface or even kind of on a stalk on the uterus. A lot of fibroids, because they're more discrete, they can be removed a little bit more easily than adenomyosis. But some patients who have fibroids may also have adenomyosis. And then patients who have fibroid surgery may be at slightly higher risk of adenomyosis as well. Just like patients who have a C section may be at slightly higher risk of having adenomyosis, or patients who've had more pregnancies are more likely to be associated with adenomyosis, or having a uterine procedure like a DNC may predispose you to adenomyosis as well because you're scraping the lining of the uterus and you may disrupt that membrane between the lining and the muscle layer of the uterus, predisposing you to adenomyosis. So these are types of things that may predispose you to adenomyosis as well. Women with fibroids often will present with heavier periods if the fibroids are underneath the lining of the uterus in their location. They may present with pressure symptoms. So if their fibroids are pushing on the bladder, they may have to go to the bathroom more often. If it's pushing on the rectum, they may have constipation. And fibroids can get quite large, as well. And I think sometimes doctors may realize that there's fibroids there, but they may not even tell the patients that they're there,
Excuse
and
me.
or they may kind of diminish the severity of them. They're very common. They occur
Yes.
in 30 to 50% of women, and so that by far outstrips the amount of patients with endo, but it doesn't even come close to the number of patients who have pain who need surgery done. So really, you're either dealing with you know mass effects of the fibroids or heavier bleeding. And again, they are amenable to removing fibroids. I do remove
Yep.
fibroids. I don't go. I don't do myomectomies on patients who have 50 fibroids.
Yep.
There are doctors out there who do that, and they enjoy doing it. I prefer to treat endo, because I feel I do that better than treating fibroids, and I refer those out to someone else. But I'm happy to, treat endo all day long. And so, yeah, fibroids are one of those things that sometimes, you know, there may be a delay in diagnosis there as well. And unless the patient's kind of complaining about symptoms, yeah, you have some fibroids, but, a lot of the times it's ignored until the uterus gets so big, it's so hard to treat that, sometimes a hysterectomy is the only option for them too. Or, really big multiple myomectomies or removing big parts of the uterus, which again will result in a less functional uterus afterwards, one that may not contract the way a normal uterus does, that has scarring within it, that may be less effective in delivering a baby if you were to try to conceive with it. But still, myomectomies are very commonly done.
Okay. So when it comes to adenomyosis, at what age does it tend to present? Anything we should be aware of at like what age group should people be aware that, oh, I'm having this particular symptom? Maybe this is something to consider in the possibility box.
Well, we've had patients, it used to be that our thinking was that adenomyosis occurred in women who were older, already had kids, you know, usually more kids, maybe a C-section or a uterine procedure done. You know, that thinking has changed. Okay. There are some studies that have found that adenomyosis may occur in even teens.
Wow.
And so it's a matter of recognizing it and trying to be proactive in managing it instead of just ignoring the possibility that might be there. So, you know, considering, you know, an IUD in someone who might be in their, you know, late teens, early 20s as a treatment option instead of not considering it because the doctor thinks, oh, the uterus is too small. It's not going to be accepting of an IUD or something like that, which is kind of an old school thought. So, you know, I think the studies have suggested that it may be more common in younger patients. Yeah, there's definitely probably a progression of it, you know, just like there is a progression of stage 4 endo. You know, we don't see stage 4 endo in many 18-year-olds. Okay.
Right.
It's very uncommon. Okay. You know, that might be like kind of one in a couple hundred. Okay. 18-year-olds. But stage 4 endo might occur in 30% of, you know, 40-year-olds. Okay. So as you get older, the symptoms of the disease may become more apparent and more of the population may be involved with it. But, you know, I've had patients in their teens who've been diagnosed with adenomyosis.
Okay.
And then it's a matter of trying to get them on appropriate treatment so that we can manage their symptoms and prevent the, you know, the problems that can, you know, result or need them to end up having a hysterectomy. So maybe considering an IUD early on, making sure that their endo is well treated so that that's one less thing that's causing inflammation and pain for them. And, you know, so just recognizing it as a possibility instead of ignoring it as a possible cause of their pain, I think is very important.
So thank you for that. So another question then is, you know, I know I've spoken to a lot of folks around the complexity of endo, and I'm curious how much this would relate to some of the patients you're seeing with adenomyosis, especially since we're talking about the pain factor as well as inflammation. There's a wonderful clinician out of Australia, Dr. Peter Wright, and she actually recently wrote a book. I haven't had a chance to read it yet, but it's on my list. And, you know, she talks about how the endo that we see is just the tip of the iceberg and there's so much underneath it. So one of them, like, I did a really interesting interview about trauma and chronic pelvic pain. And it just made me think about this when you were talking about the young girls, you know, also like different things we can do through diet and many other factors around inflammation. I guess I'm curious if you have any comments on the adenomyosis side of this related to trauma, anti-inflammatory things that one can do in relation to the pain and other factors for adenomyosis.
Yeah, adenomyosis is a very inflammatory condition as well. It's a little bit more localized because, you know, it's not outside, like, you know, throughout the pelvis. Often it's just within the uterus itself. Okay. So that may help to kind of contain some of that inflammation as opposed to kind of, you know, being, you know, affecting the bowel as much because the endometriosis can be, you know, endometriosis releases a lot of inflammatory mediators, and the small bowel and the large intestine kind of float in this soup of inflammatory mediators. Okay.
That's fair.
So when you remove the endometriosis, you're kind of decreasing some of the inflammation on the bowel itself. Do I recommend an anti-inflammatory diet for everyone with endo? Well, if you treat their endometriosis and they have very little endometriosis left, you know, the idea of treating endometriosis and what we see is the tip of the iceberg. Well, when we look in a pelvis, yes, it can be. And unless you're excising the disease, you're not removing the full depth of it. But, you know, we can be like an icebreaker and we can remove that entire iceberg, so to speak, if we do proper excision and we're removing the full depth of the disease. With adenomyosis, it's a little bit more difficult to do that. And so maybe an anti-inflammatory diet may be even more important for those patients, because you know that until they have hysterectomy, that inflammation is still there. Okay, so at a minimum, and it's to some extent, it depends on the types of symptoms that they're having. Okay, patients who are sensitive to gluten and lactose, I have them avoid those things. Okay, that's a non-starter for those patients who have a lot of bowel symptoms, because that can be helpful for a significant portion of them. But then it comes down to an anti-inflammatory diet if you're still having symptoms. Okay, maybe you have more of a systemic impact of your disease on your entire body. And so by having an anti-inflammatory diet, which involves organic fruits and vegetables and organic meats. And what are organic meats, right? Well, that's grass-fed beef and free-range chickens that aren't fed products with cattle, especially soy, because the soy gets incorporated into the cell membranes of the animal as well, and that can have an inflammatory effect on their body and then our body as we take it in as well. And so avoiding processed food, trying to eat naturally, is a very big part of approaching an anti-inflammatory diet. And so I encourage that for most patients, especially if they're having any symptoms. Does that mean that as a patient who's had a diagnosis of endometriosis and you've had a good excision, that you can't eat some foods? I think it's a matter of experimentation. And I think a lot of people are able to open up their possibilities for what they eat in their diet. I'll have a lot of patients who say, oh, I can't eat this or I can't eat that because it just flares their inflammation or makes their pain worse. But after surgery, I've seen many patients who've been able to kind of resume a more normal diet. Years ago, there used to be this idea of an endometriosis diet, and there were like 30 things on it you could eat. Right. It's like you could eat squash. I can't even remember. It was so restrictive. It's like, I think I had one patient out of the 10,000 plus that I've seen that had been on it for more than a few years. Okay. Wow. Because it was so restrictive. And I've had other people who've tried the endo diet, and I don't know how well researched it was, whether it was just someone who kind of came up with this idea. But I think the idea of an anti-inflammatory diet is much more well accepted.
Yes. Okay. No, that makes sense. It is experimentation. And for those who are frustrated, I can once you figure out your formula that works for you, it's like no hesitation. Because I remember I was hesitant in the beginning. Dr. Braverman and I had a lot of debates over what I could and could not eat. And then I felt great. And I was like, okay, fine, you're right. What is it that you want women to know, and how do they advocate?
Well, I think part of it is to just realize that it often goes hand in hand with endometriosis. Okay. One of the things that I think is a bit of a misconception is that, women with endo all have heavier bleeding. Okay. And a lot of them don't necessarily have heavier bleeding because of their endo. A lot of it is probably uterine mediated. Okay. You can have hormonal causes for heavier bleeding. You can also have adenomyosis is a big cause of heavier bleeding. And so if you have heavier bleeding, that might be a bit of a red flag that maybe I have adenomyosis as well. Okay. One of the other things I think I mentioned was kind of just uterine cramping all the time, or pain after sex that may last 2 or 3 days, where you're just very achy afterwards because the uterus has kind of, been traumatized a little bit with that. I think that just bringing it up to the doctor too is like, if you're aware of, that you might have endo, you're just bringing up the idea that, well, what do you think about adenomyosis as well, doctor? Do you think this could be a possibility? Because, ones who are maybe a little bit more astute will say, yeah, that's a possibility, but, let's do the imaging. Let's do, try some things to see whether or not the uterus responds in a favorable manner. And that way we can see whether or not that's part of the problem. And again, it depends on what the goals are, right? And I think you talked about trauma earlier, and I don't know if I really addressed it very much. The idea of trauma and causes of pelvic pain, and I don't think that trauma per se increases the likelihood of endometriosis per se. I'm one of those believers who believes that you were probably born with endometriosis. Okay. If you look
Okay.
at some of the studies that look at stillborn fetuses, about 10% were found to have endo, which is the same
Wow.
incidence as the population. If you look at the idea of retrograde menstruation, which Dr. Sechkin tends to believe in, but I don't. And the reason for that is endometriosis produces its own estrogen, but the lining of the uterus can't. Okay, so that tells us they're biochemically different. And so once it becomes implanted, does it undergo biochemical change? I don't think that makes a lot of sense. So I think that these are things that have been laid down early on. And for chronic pelvic pain, once you've treated their endometriosis and if you've explored their social history and seen whether there's a history of either sexual abuse or physical trauma or rape or incest, that those could be causes of persistent pain or chronic pelvic pain in those women. But I don't think it's kind of one of those umbrellas that affects all women with endo. It's really kind of one more of those things that's targeted towards patients with chronic pelvic pain.
So then is it fairly straightforward once imaging is done to find the adenomyosis, or is there an art to that?
Well, there are definitely many features that we can look to on imaging. And so, really, the two most common imaging that we have for adenomyosis are ultrasound and MRI. Okay. And if you're on hormonal suppression, the MRI may not be quite as sensitive, and there might be best times to do it during a cycle. If you're worried about this, sensitivity of the MRI, you're probably better off doing it right before a menstrual cycle, because at that point the uterus is probably the most inflamed,
Okay.
right before you have your period, because the lining of the uterus has kind of thickened up, and so those areas of endometriosis within the muscle layer gotten bigger as well. The features on an MRI, you can look at the junctional zone, which is the space between the endometrium and myometrium. You can also look at the posterior wall of the uterus, which is often thicker in patients who have adenomyosis. It's an asymmetry between how thick the front wall of the uterus is and how thick the posterior wall of the uterus is. Whether or not you're seeing deposits within the myometrium that tend to kind of highlight when the contrast is given. So those are kind of some of the more straightforward features that you can see on MRI. On an ultrasound, you'll see again the asymmetry of the uterine walls, the posterior wall usually being a little bit thicker. You can see heterogeneity or different color or black and white textures within the muscle layer of the uterus to suggest that there's adenomyosis there. Sometimes you'll see something that we call lakes or little pockets of blood within the muscle layer as well. And just the overall size of the uterus as well. So if you have, say, someone who's maybe your age and you've had kids, maybe your uterus is around 8 centimeters in length. Okay. Someone who has adenomyosis, their uterus may be 10 centimeters in length, and it may be thicker as well. So those are subtle things that we can sometimes see just on ultrasound imaging as well that are suspicious for it. And just the physical exam too. So, when you examine a patient, one, you want to rule out pelvic floor dysfunction. So that's always something that we do, because that can be a cause of pain after surgery as well that needs to be addressed. And so we want to identify their pelvic floor dysfunction, and then we examine the cervix to see if it's painful, which is probably more likely associated with adenomyosis than endometriosis. And then you want to examine the body of the uterus to see whether it's if it's really tender to palpation, as opposed to trying to find nodules with endometriosis in certain locations, whether or not the ovaries are enlarged on a pelvic exam, which is a separate issue. But there are definitely a lot of features that you can pick up on physical exam as well that are confirmatory or make you more suspicious of it. And so you really have to do a very systematic exam on patients so that you can get as much information and the right information to help point you in the right direction.
Okay, thank you. So I guess last question then is, I know with endometriosis, the theme I hear over and over again is you have to find the right surgeon. Ideally, a center like yours where there's a multidisciplinary team. I know not all over the country do people have access to that, which is why they have to fly to centers like yours, which is great to have access to you, but costly and all that good stuff. Is there a same concern with adenomyosis that we have to make sure we find the right doctor? Because here's my fear is that clearly a hysterectomy will get rid of it, but if someone doesn't want a hysterectomy, or they want to have, just generally like never want to have it, or they want to have children and they haven't had their children yet, they would want to delay. So is there a risk with this that someone may get a hysterectomy when there were other options? And if that's the case, like how does someone navigate? Is there the sense of urgency of finding you or is
Yeah.
it more of just
Well,
how they talk to their doctor?
yeah. And everything comes down to what your goal is, right? And I think you just have to be very um, firm and adamant about what your goals are.
Okay.
Um, is your goal getting out pelvic pain, or is your goal, I want to try to manage my pain with whatever options are out there because fertility is an important option for me? And then we try to, hopefully the right doctor will exhaust those options before they consider hysterectomy in those patients. And how many patients have I had that have regretted a hysterectomy? Well, probably a handful, like a couple.
Okay. Oh,
I
wow.
think
Okay.
I've had a couple of patients out of maybe 2,000 hysterectomies that I've done. Okay,
Okay.
so most patients do not regret having had a hysterectomy if their pain is bad enough that we've exhausted all the other options for
Okay.
them. Have they had an excision surgery done if we suspected endometriosis? Do they still want to have kids? And in those situations, we'll try to jump through all those hoops to,
Hmm.
do everything we can to try to get them feeling better. And sometimes at the end of the day, that might be, the choice is, okay, do I live with some level of discomfort or heavy bleeding? What can I do to kind of optimize those situations? And then if you're feeling good enough that you don't need a surgery, great. But some of them may end up progressing on to that kind of as their last option. But yeah, it's one of those questions that's very difficult for me to answer because I just don't know what patients are being told by their other specialists regarding adenomyosis. A lot of the time, patients, when they come into my office, adenomyosis, they're hearing it for the first time, because their
Wow.
other doctors haven't brought it up.
Okay.
And so that's why I think, I go about educating my patients regarding
Hmm.
it,
Okay.
because, most primary care gynecologists, who, your primary care doctor sends you to their gynecologist, or you go to your OB, who's your gynecologist as well. A lot of them are OBs first and pelvic pain specialists fifth. You know,
Yep.
they're dealing with all these other things that are gynecologic related, and pelvic pain and endometriosis may be way down their list of skills and or priorities. And so it's hard for me to know where that lies with them. And I give most gynecologists the benefit of the doubt and say that they
Yep.
try to stay on top of things and try to be proactive for their patients and not do unnecessary surgeries. But at the same time, I have seen patients who've had
Okay.
unnecessary surgeries or poorly done surgeries and have had diagnoses ignored too. So I'm kind of a little bit jaded because of my
Yeah.
experience with patients.
Right. No, I get it. And I mean, this is why, I wanted to bring you on to talk about this because you're one of the few last lines of defenses that people go to. And so it's really important to hear what you're seeing so that those who are on the front end as patients know how to advocate and what they need to advocate for. So this has been helpful.
These sort of venues here with your podcast, and I do a lot of other podcasts or talks for patients, that are really, I probably do more patient oriented talks where it's just trying to learn information and educate patients. And I do international talks at conferences as well. This month I'm giving a talk at the AAGL, which is the American Association of Gynecologic Laparoscopists, on endometriomas. But, where I'm one of the experts on the panel, these are the things that I feel are more beneficial because they're the ones who are informing the patient so that they can be aware of what they need to learn, what they need to ask their doctors, so that they can be well prepared going into seeing their specialists and hopefully getting the right answers, or at least coming in with a little bit more knowledge than they would have otherwise.
Yeah.
So that's
absolutely.
why I love doing these things.
Oh, well, thank you so much for making time. I really, really appreciate it. And it's such a joy to get to know you. You have such a gentle way about you. This has been like just such a wonderful time. And I'm so grateful for your time. I can't wait to share this. And I'll put in the show notes all the ways that people can contact you and be in touch with your center. And just really, really appreciate you sharing this information. I know it will help so many women who are struggling.
Absolutely. Anytime you want to discuss anything endo related, I'm there.
Awesome. And that wraps up another empowering session here at the Fempower Health podcast. Now, before you dash off, I've got a quick, exciting invitation for you. Please join our vibrant community by subscribing to our weekly newsletter, because it's really your frontline update on groundbreaking women's health research, the latest health-enhancing products, fun quizzes to boost your health IQ, and unique discoveries that you won't want to miss. All of this delivered straight to your inbox, cutting through the noise of social media algorithms. Love today's insights? Show your support by rating and reviewing our podcast. Your feedback is more than just a pat on our backs here at Fempower Health. It lights the way for others seeking guidance and community in their health journey, amplifying the voices that need to be heard. And for a deeper dive into today's topics, check out the show notes and explore our website at fempower-health.com. Our site is a treasure trove of knowledge, neatly categorized by topics of interest and life stages, ensuring you find exactly what you need to empower your health journey. And your voice matters to us deeply. Whether you have a question, a story to share, or feedback on our episodes, reach out directly at info@fempower-health.com. Drop us a message on social media or hit reply on any newsletter. Your insights inspire our conversations. And a quick note, the knowledge we share is here to embolden you in discussions with your healthcare provider. It's not medical advice. Always consult with your doctor for health decisions. And remember, the diverse perspectives of our guests reflect their individual journeys, and it's not an endorsement by Fempower Health. Here's to empowering your health journey one episode at a time, and I'll see you on the next Fempower Health podcast episode.